Klebsiella pneumoniae as well as for the Staph aureus, that is for the MRSA. So the issue in front of us was that even despite on being this broad spectrum antibiotics, he still had this persistent empyema. This was still persistent despite on these broad spectrum antibiotics. So what did we do? We looked back into the culture reports more diligently, and when we look at Klebsiella pneumoniae, this was indeed a carbapenem resistant Klebsiella pneumoniae with that time sensitivity to colistin, Tigecycline was sensitive. We also looked into the tetracycline sensitivity. So tetracycline was not reported, but minocycline sensitivity was reported in this patient with a MIC of 2. Now we looked again at the Staphylococcus aureus MRSA sensitivity. So here the TG-cycline was sensitive, minocycline was not reported, but tetracycline was sensitive. So when you have tetra-sensitive and TG-sensitive, minocycline is likely to be sensitive. So in this patient, can we use minocycline for treating this empyema? So these were the various factors which we considered while choosing the antibiotic. So we looked into the spectrum of activity of each of these antibiotics and looked into the lung concentration because that is the site of infection, looked into the various susceptibility breakpoints as well as the possibility of oral conversion. So when we look at colistin has activity only against the gram negative. So it will have activity against the Klebsiella pneumoniae, but it will have no activity against the MRSA, right? Tigecycline is a broad spectrum antibiotic which has activity against the gram negatives, gram positive, MRSA, it's static, and also against the anaerobes. And similarly, minocycline also has activity against gram negatives, gram positive, as well as the anaerobes. Coming to teicoplanin, that has activity only against MRSA, and it has no activity against the gram negatives. When we talk about the penetration into the site of infection, colistin, as we all know, has sensitivity of only 25%, has limited penetration, and so is the penetration of tigecycline limited into the lungs, and that is why it is not indicated for VAP and is associated with increased mortality. Coming to minocycline is a drug which has got reasonably good penetration into the lungs. And in fact, when we look at the susceptibility criteria, so for colistin now the susceptibility criteria has changed. It's either going to be reported as intermediate or resistant. Tigecycline as such has susceptibility criteria only as per the UCAST for E. coli. It does not have any criteria for Klebsiella pneumoniae. We are just extending the susceptibility criteria to these bacteria. Coming to minocycline is an age-old antibiotic with stringent susceptibility guidelines established for Enterobacteriaceae as well as for the Acinetobacter baumannii. And here we can see that this if it is sensitive, that is with a MIC of less than 4, and in this patient it was 2. So it is susceptible and can be considered as an antibiotic option. Besides, of all these antibiotics, minocycline is a drug where there is a possibility of oral conversion. So in this patient, as the source control was already performed by the surgeon, we discontinued colistin, meropenem as well as tigecycline. All were discontinued, and this patient was initiated on IV minocycline initially. And look at the response. Within like a few weeks, there was a significant response. And by November, with 8 weeks of therapy, the patient had resolution of the empyema. He received initially IV for 2 weeks, and subsequently minocycline orally was given for 6 weeks. And this actually had a drastic saving in terms of the healthcare cost by approximately close to 9 lakhs. So that's how an interpretation of the lab results by a clinician or an ID physician can actually help in optimizing the therapy and reducing the healthcare cost as well. Now let's look at this patient. This is a 22-year-old gentleman with road traffic accident, and in this patient, as we can see here, this was the culture which was showing the Pseudomonas aeruginosa, and this was sensitive to colistin. As well as, if you can see that this was also found to be sensitive to ceftazidime. Amikacin was also considered to be sensitive. Besides, we had the sensitivity to fosfomycin. So the issue here in front of us was, should we use colistin and fosfomycin, or can we use ceftazidime in this patient, as this is sensitive? So when we look here, this is the meropenem is actually intermediate or resistant. Imipenem is resistant, but you have a beta-lactam ceftazidime which is sensitive. So we have to, there is a discrepancy here, and we went ahead and requested our microbiology to look for any inducible AMC, which was tested by placing the ceftriaxone disc close to imipenem. And as we can see, there was a flattening of zone around the disc, which is suggestive of an inducible AMC. So in this patient, ceftazidime cannot be used for the treatment. The next step is, can we perform any other tests which will help in the management? So yes, in this patient, a Cepheid Carba R can be performed, and it detected that there was a OXA48, which was the resistant mechanism. So when you have OXA48, you can use other antibiotic options like the ceftazidime avibactam, which can be used for the treatment of this particular infection. So the take home message is basically, even if the culture report is available, it's careful interpretation and clinical correlation of the lab results which will help us in choosing the antibiotic therapy. And this can be done obviously with a more thorough knowledge uh, of the subject. So these basically, an ID physician has value in treatment of infections across specialties, particularly if there's infection in immunocompromised host like the transplant and oncology. If there's infections in the ICU, which are usually associated with complicated drug resistant infections and are complicated fungal infections. For the treatment of MDR, XDR infections, particularly with tuberculosis, non-tuberculous mycobacteria, and fungal, nosocomial device and implant-related infections, complex infections like the endocarditis, urinary tract infections, bone infections, HIV, meningitis, skin and soft tissue infections, intra-abdominal infections, which are at times very complicated. For PUOs, pyrexia of unknown origin, which could be because of it could be infective or non-infective etiologies. An ID physician can also carefully look into the various PKPD parameters as well as the drug interactions while the antibiotics or the antimicrobials are being used. Also, we can advise regarding the appropriate test and avoid unnecessary therapy. Definitely, as shown by the previous cases, there is an immense role of an ID physician for the antimicrobial stewardship, infection control, as well as for academics and teaching the various clinicians as well as students. And I hope this presentation will also help in actually picking up some key points which will help us in our day-to-day clinical practice. So the value of an infectious diseases specialist has been studied, and there are several publications now. This was one of the first publications in 2014, this which actually included more than 130,000 patient cases. And they found that having an ID specialist involved in the care of a patient who has a severe infection will actually lead to better outcomes. In fact, the results showed that an early ID involvement was associated with a 3.8% shorter overall index stay, shorter ICU stay, as well as a close to 3.4% lower Medicare payments, as well as the 30-day mortality was also significantly lower. To summarize, basically, infectious diseases has cut across the usual boundaries set by the medical specialist. Most infectious diseases, they can be cured if diagnosed early and treated appropriately. The difference between the most appropriate treatment and its closest alternatives is actually wide, and this makes the management of these infections challenging as well as rewarding. And of course, we need inputs from all specialties, including microbiology, radiology, histopathology, as well as the other clinical specialties for managing these clinical problems. As we all know, it's actually success which comes by working together with a long term strategy. And I'm really thankful to my mentors, Dr. Rajiv Soman and Dr. Kamala Rodrigues, for teaching us infectious diseases. Thank you so much.